Welcome back to The Explainer. Today, we're throwing on our medical detective hats. We're digging into the core concepts from the textbook Differential Diagnosis in Dermatology by Richard Ashton and Barbara Lepart. It's this incredible resource that treats skin conditions way less like a frustrating guessing game and much more like a highly structured medical detective story. I am so excited to guide you through this. So let's get focused, examine the evidence, and crack this case. You know that moment when you spot a weird rash on your arm and think, what on earth is that? It's super easy to just throw out a wild guess. But the text we're looking at today explicitly warns against doing that. Dermatology, when done right, isn't a guessing game. It is a logical, highly structured science. It's all about systematically gathering clues before jumping to conclusions. Okay, let's dive right in. We've got 5 precise phases to crack this case today: solving the skin mystery, decoding skin lesions, investigative tools of dermatology, principles of skin treatment, and finally, creams, ointments, and steroids. Kicking things off with phase 1, solving the skin mystery. So imagine a patient walks into the clinic. The investigation starts with this incredibly sequential, descriptive checklist. It's basically the medical detective's primary tool. Step 1, note the site. Like, where exactly is the rash? Step 2, check for erythema. Is it red? Step 3, determine the duration. Are we talking acute, like under 2 weeks, or chronic? Step 4, feel the surface features. Is it smooth? Is it scaly, crusty? Step 5, classify the lesion type. And step 6, define the border. Does it just kind of fade into the skin, or is there a sharp, accentuated line? By following these exact steps, a doctor can dramatically narrow down the suspect list without a single wild guess. It is literally an algorithm for the human body. Moving right along to phase 2, decoding skin lesions. This is where we gather physical clues by actively looking at and feeling the skin. And this brings us to one of my absolute favorite, elegantly simple physical checks, the glass slide test. If you press a clear glass slide against a red rush, does the redness disappear? If it blanches, turns white, that's erythema. The blood vessels are just dilated. But if it does not blanch, no way. That means blood has literally leaked out into the surrounding tissues. That's purpura. One simple physical action, massive diagnostic clues about what's going on beneath the surface. Look how perfectly this categorizes the physical geometry of these lesions. If it's flat and under a centimeter, it's a macule. Bigger than that, it's a patch. If it's raised and solid, under a centimeter is a papule, larger is a nodule. And if it's fluid-filled, a tiny one is a vesicle, and a larger one's a bulla. Memorizing this grid is basically how the medical detective organizes the crime scene. Figure out if you're dealing with a papule or a vesicle, and boom, you've just eliminated half the diseases in the book. But deep palpation is also absolutely crucial here. And there is this wildly relatable analogy for it. Soft lesions feel easily compressible, exactly like your lips. Go ahead, actually feel your lip for a second. Firm lesions, on the other hand, feel solid with just a tiny bit of give, exactly like the tip of your nose. It's a genius way to standardize what soft and firm actually mean clinically, so every single doctor is literally on the same page. All right, phase 3, investigative tools of dermatology. Because sometimes the naked eye and a fingertip just aren't enough. First up is dermoscopy. This is where you view the skin surface through a magnifying lens with polarized light. It lets the doctor see right through the surface glare to assess pigment depth and vascular patterns. What they are really hunting for here, especially when they suspect malignant melanoma, is chaos. We're talking multiple colors, asymmetrical structures, irregular borders. Dermoscopy brings that chaos to light. But wait, there's a whole CSI lab toolkit here. We've got the Woods light, which is a UV filter that makes certain fungi and bacteria glow these crazy fluorescent colors, like green for ringworm. Bacteriology cultures, swabbing to identify the exact bacterial culprit. Mycology, where skin scrapings are mixed with potassium hydroxide to spot fungal structures under a microscope. And patch testing, to identify those delayed type 4 hypersensitivity allergic reactions. Speaking of patch testing, the number 48 is incredibly important. Why? Because it takes exactly 48 hours for a patch test to reveal a localized allergic contact dermatitis response. The doctor tapes the suspected allergens to the patient's back, waits exactly 48 hours on the dot, and then removes the tapes to see if a tiny plaque of eczema has formed. Patience is definitely key in dermatology. That brings us to phase 4, principles of skin treatment. We've cracked the case. Now we deploy the exact right therapeutic solution. Before we jump into chemicals and compounds, we have to ground this in human empathy. Check out this powerful rule. Look at the whole person and not just at their rash. Skin diseases are highly visible, right? They can cause profound psychological distress, embarrassment, self-consciousness. A great doctor treats the human being, acknowledging how the condition actually affects their daily life and their self-esteem, not just treating the biological surface. Now for the science of the cure. Every single topical treatment is a two-part system. You've got the vehicle, the base, plus the active constituent, which is the medicine itself. Picking the perfect medicine is completely useless if you put it in the wrong base. The base's entire job is to transport that medicine into the skin, entirely depending on how hydrated or dry that specific patch of skin is. Which leads perfectly into our final phase, phase 5, creams, ointments, and steroids. To really nail the difference between these bases, food analogies work wonders. Creams are oil and water emulsions. They absorb easily, kind of like milk. But because they contain water, they absolutely need preservatives to stop bacteria from growing. Ointments, totally different. They are greasy, basically no water, and they trap moisture, much like butter. If a patient has really dry, scaly eczema, giving them a watery cream might just evaporate and make it worse. They need the butter. They need the ointment. The base matters just as much as the drug. Next up, topical steroids. Incredible tools for reducing inflammation if used correctly. Here are the rules of engagement. 1% hydrocortisone is weak, safe for delicate areas like the face. Moderately potent is your go-to for eczema on the trunk and limbs. Potent steroids are kept strictly for localized, incredibly stubborn eczema. And very potent steroids, actually rarely used in general practice because of the severe risks. The absolute golden rule here is always use the weakest possible effective dose. But how do you actually measure a dose of ointment? Enter the fingertip unit, or FTU. It's just the amount of ointment squeezed from the tip of the index finger down to that first joint. It is a brilliantly practical measurement system, so doctors and patients don't underprescribe and fail to heal the rash, or overprescribe and cause real, lasting damage. So how does the FTU play out in practice? Well, to safely cover an adult face and neck, you need 2.5 fingertip units. One arm, that takes 3 units. A leg takes 6 units. The front of the trunk takes 7 units. It takes the guesswork entirely out of applying medication, giving patients a super clear, actionable guide for their at-home treatment. And why are we so incredibly strict about steroid dosing? Because of the forensic consequences of getting it wrong. Long-term use of potent steroids carries some gnarly side effects. We're talking skin atrophy and thinning, tearing and strange stellate scars, easy bruising because the dermal collagen has basically been destroyed, and a severe rebound worsening of the rash if you stop the medication suddenly. It is powerful medicine that commands profound respect. So we've journeyed from looking and feeling all the way to diagnosing and precisely treating, which leaves me with one final, kind of provocative question for you. Now that you know the system, will you look, feel, and describe like a medical detective, or will you just guess? I hope this explainer showed you just how fascinating and structured the world of dermatology really is. Stay curious, keep learning, and I'll catch you in the next one.